Hi, good morning, and welcome to Grand Rounds on this beautiful winter Thursday. Just two quick housekeeping items. The first is I've been asked by a number of people, if you've not yet gotten your flu shot, first of all, be aware that folks are aware that you haven't gotten your flu shot. And second, that once again, there'll be nurses, I think they're already there in the lobbies of both hospitals, providing flu vaccines. So I encourage you to take a few minutes to do that. They'll be there throughout the day, but as I say, I've already set up shop at both sites. Separately, of course, Employee Health Services is available to get your flu shot there as well. Also, for the friends at Mount Sinai West, just be aware today there's a meeting starting right at 9 a.m. At our party last night, one of the Mount Sinai West leadership asked me to ask you to get out of the room right on time so they can get started. And I think there's a series of events in the conference room downtown, so they're just worried about not getting backed up. So it's really a pleasure for us to have Dr. Jacqueline Tamis-Holland with us. All of you know Dr. Tamis-Holland is a wonderful friend to the Department of Medicine, both in terms of the remarkable clinical care she provides to some of our sickest patients, and also for the major contributions she makes to our educational mission. Dr. Tamis-Holland is an associate professor in cardiology at the Icahn School of Medicine at Mount Sinai. She's also the director, as you know, of the Mount Sinai St. Luke's Interventional Cardiology Fellowship, as well as being the director of the General Cardiology Fellowship at Bronx Care. And for those who are not aware, that's a separate affiliated fellowship that we have. One of our graduates from the coming year will be participating in that program. And they do great care in the Bronx. And Jackie, I don't know how you do it, but she gets back and forth between the two institutions supporting the educational mission for our fellows. She did her undergraduate degree at New York University, where she majored in chemistry, and I think could have had a career as a chemist, winning awards in that regard, and then also went to medical school at NYU, and then followed that with her internship and residency in internal medicine at Bellevue Hospital Center. She then completed 2 fellowships here. She completed a clinical cardiology fellowship and interventional cardiology fellowship at Mount Sinai St. Luke's, and has been, as you all know, a wonderful contributor in the department and in the hospital. To review Dr. Tamis-Holland's CV and see what major contributions she's made nationally and internationally in 2 particular veins. One is helping us to think much more systematically in an evidence-based way about how we manage acute coronary syndrome. That's, of course, a topic for our discussion today. And the other is making us much more acutely aware of how cardiovascular disease affects women, and making sure as we think about how they present symptomatically and how we provide care to them, we're really knowing in as much detail as possible what their particular syndromes look like and how to best address those. Jackie, it's really wonderful to have you with us today, and welcome.
Good morning, everybody, and thank you so much, Dr. Seward, for that really very flattering and beautiful introduction. And thank you to the Chief Residents for inviting me to be here. As all of the residents know, MINOCA is one of my favorite topics to discuss, and I'm happy to be able to talk to you about it. So thank you. So I'm going to start with a show of hands. We don't have an audience response system, but I'd like to just have people raise their hands if they've never heard the term MINOCA before. Wow, so this is great. So hopefully I'll be able to do some good. And how many of you are familiar with the term MINOCA and use it regularly on diagnosing your patients? Okay.
I'm familiar, but I don't use it regularly.
Okay, great. Okay, so I feel like I'm here to do some good. If nothing else, if I just stop at the next slide, I can leave. It's good. So the term MINOCA refers to myocardial infarction with no obstructive coronary artery disease. And it was originally coined by Dr. John Beltrami approximately 8 years ago. Originally, they used to call it MINCA, which referred to myocardial infarction with normal coronary arteries. But over time, they realized that there are patients, a good deal of patients who have non-obstructive disease, and so they expanded the term to say MINOCA. And over the last 15 to 20 years, there's been numerous articles and publications on patients who went for angiogram because of an acute MI and had non-obstructive disease. And they reported on the incidence and the characteristics of the patients and their outcomes. And there's a lot of variability in the results of the study, and that's probably because of the fact that there's been different definitions for the term MINOCA. So it really wasn't until the last couple of years that we've had two really important contributions to the literature, one by the European Society of Cardiology and one by the American Heart Association. And in these documents, they sort of were able to provide a formal definition for MINOCA, outline a diagnostic algorithm for how you would approach patients with MINOCA, and finally provide some information regarding the potential treatment and outcome of patients with MINOCA. So on the basis of these papers, on the basis of the prior publications, I'd like to spend the next 30 to 40 minutes overviewing with you MINOCA. I'm going to go over with you the definition, the epidemiology, the etiologies for MINOCA. I'm going to talk to you about a nice little algorithmic assessment that we can do to assess our patients with MINOCA, and I'm going to focus a little bit on treatment and finally prognosis. So the definition of MINOCA is pretty pragmatic. It's pretty intuitive and obvious. It's basically a patient who's had an acute myocardial infarction, and on angiogram they have evidence for non-obstructive disease. So officially disease that's less than 50% stenosed. And then you cannot have any other underlying reason for your presentation. So if you have an elevated troponin and you have non-obstructive disease on CAV, but you're found to have myocarditis, this would not be included as MINOCA. So the definition is pretty obvious, but where I think that the issue becomes a little bit more important to emphasize is that you need to have a myocardial infarction in order to have MINOCA. That's, the word myocardial infarction is in MINOCA, M-I, myocardial infarction. So you first have to have a myocardial infarction. And this again boils down, I'm going to take sort of a step back, and all the residents in the room know because I drill it into them again and again and again, the difference between myocardial injury and myocardial infarction. So this was very nicely shown in the fourth universal definition of MI, which was published last year, in which they said that myocardial injury is a situation in which you have an elevated troponin. If it's chronically elevated, there isn't a rise and fall, it's more of a chronic myocardial injury, and if there's a rise and fall, it's more consistent with an acute myocardial injury. Among the many things that can cause myocardial injury, there can be an ischemic mechanism to myocardial injury, and that's a myocardial infarction. But if there's not an ischemic mechanism, this is just myocardial injury. So to put it to you in the broad picture, the pink circle is myocardial injury. And within this pink circle, you can have a smaller subset of patients who have myocardial injury as a result of an ischemic mechanism. But you can see that there are a lot of other situations in which you have myocardial injury, and it's not necessarily an infarction. So this is becoming increasingly more important to understand and to make sure we're reporting that when we're documenting in the chart, etc. Again, the talk today isn't on myocardial injury in type 1 and type 2 MIs, but the bottom line is in order to be MINOCA, you have to have an infarction. So just because you were taken to the lab for an elevated troponin and you have non-obstructive disease, it doesn't necessarily mean you're MINOCA unless you've had a clinical symptom of infarction. So there's been numerous studies, as I've pointed out to you, looking at the incidence, the prevalence of MINOCA in the population. And as you can see, this is pooled data done by Pasupathy and colleagues. And you can see that the range of MINOCA is, in some studies, as low as 1% of the population of MI patients to as high as 14%. You take the pooled data overall, the overall prevalence of MINOCA is approximately 6%. You look at more contemporary data, this again is the Pasupathy pool data, the incidence. You see that again, the incidence really ranges to approximately 5 to 6%. The Verba study was a study of patients, women and men, but predominantly women, enrolled in a registry, and they had to have an infarction if they were less than 55 years old. So you can see the incidence of MINOCA in this population of patients was a little higher, but that's because they're enrolling or looking at a younger population. So overall, MINOCA patients are generally younger than patients with MI and coronary artery, obstructive coronary artery disease. There's a larger proportion of women with MINOCA representing the MINOCA population compared to women with MI and coronary artery disease. and approximately 15 to 30% of MINOCA patients present with STEMI as their initial presentation. So I'm going to go into the MINOCA etiologies, and I think that it's important to understand that MINOCA, like syncope, is really a syndrome. It's, syncope is a diagnosis, MINOCA is a diagnosis, but it's really a syndrome. Syncope is just the presentation, somebody's collapsed. But then the question is why? Was it vasovagal? Was it bradycardia? Was it tachyarrhythmia, et cetera? And it's the same thing with MINOCA. Somebody presents with MINOCA, and now the question is, what is the underlying reason for it? So MINOCA is just sort of like the presentation or the syndrome, and then you need to understand the etiologies. So before I go any further, Ashish isn't here now, but I'd like to give a big congratulations to Ashish. He drew these pictures. When we had prepared our document last year, the reviewers had commented that we didn't have enough nice, beautiful pictures. And of course, I was, well, what do you do? I mean, I don't draw, and I don't know who can draw. So I was sitting in grand rounds waiting for it to start. And I asked Ashish, hey, do you know any of the residents? Because he was the chief resident. Do you know any of the residents who draw? And he told me that he has a great interest in illustrations, and he subsequently bought his little colored pencils and did these absolutely beautiful pictures for us. So congratulations to him, and he has a publication in circulation because of it. So we have here the different etiologies. So you can have plaque rupture or plaque erosion, which are basically the same way you can have that in patients with coronary disease and obstructive coronary disease. You can have an in situ thrombosis on top of a relatively normal endocardium, and that can be patients with hypercoagulable states, or you can have embolic thrombosis from distally. You can have SCAD, you can have supply-demand mismatch with essentially normal coronaries, you can have epicardial coronary vasospasm, or you can have microvascular spasm or microvascular dysfunction. So these are all the possible causes of MINOCA, and I saw a case report recently of a MINOCA case because of external compression of the coronaries, which was interesting. So you can have different causes, but these are the main causes you want to think of. And it's important for us to think of these things because we want to try to consider what sort of evaluation we would do based on what the patient's presenting and how likely these things are. So much like patients with obstructive disease and MIs, MINOCA can be either from a type 1 infarction, i.e. plaque erosion or plaque rupture. In these cases, the erosion or the rupture didn't result in a thrombotic occlusion to the point where it caused obstructive disease, or if it did, by the time they got to the cath lab, they had thrombolyzed and things were better. Or you can have MINOCA from a type 2 infarction, just like you would see in other patients with disease. So you can see MINOCA, just like I said, with coronary vasospasm, supply-demand mismatch, and SCAD. So again, type 1 and type 2, is just the type of the etiology for how somebody had an infarction. And MINOCA can be either one, either due to plaque rupture or other things. So
the pictures show more than 50% occlusion.
Oh, sorry. So this is taken from the universal definition of an MI with obstructive disease. So I was just sort of paralleling it, and this one too. So I was paralleling it to the fact that similar to MIs with obstructive disease, you can also have type 1 MIs from MINOCA. That's what I was trying to say. Sorry about that. Okay, so there's a traffic light sequence for an algorithm for assessment of patients with MINOCA, and it's useful because it sort of gets you to think about the etiology and then gets you to understand the different ways in which you can treat the patients. So what I'd like to do is to take you through step by step the traffic light sequence, and of course we call it the traffic light sequence because it's red, yellow, and green lights. Okay, so the first thing we want to do is red light, stop. You have somebody, they've come back from the cath lab, the interventional cardiology fellow tells you there's non-obstructive disease, and they're on team C, they were admitted with a troponin of 0.9. First thing you want to do is stop. You want to go back and look at the clinical context. Did this patient have a clinical syndrome of an acute myocardial infarction before we even start to say to the patient, we've had MINOCA, we should consider the evaluation. So first you want to say, did the patient have sepsis? Did the patient have PE? Something else that's not even a myocardial infarction at all, it's a myocardial injury. So here's an example of a case from the other day. Patient presented with fevers to 103, multiple episodes of vomiting. She was seen well in the nursing home a couple of days ago, but she had some loose bowel movements, and she had a Foley catheter drain, which drained pus, and she had troponins that were 0.489 to 0.352. I'll be honest with you, I still don't understand why we're doing troponins in somebody with pus in the urine, but the bottom line is the troponins had pus. The troponins were elevated. So now this patient didn't go to the cath lab because it was just from the other day, although maybe she will be showing up in our cath lab soon. But she didn't go to the cath lab yet. But had she gone to the cath lab and came back to the floor and you saw that there was non-obstructive disease on the cath, you're not going to go back and tell the family or tell the patient, well, you had MINOCA, because this wasn't MINOCA in the first place. This is not an MI, this is a myocardial injury. So that's where the stop sign comes in. You want to be sure that somebody doesn't have MINOCA. Doesn't have an MI or has an MI. So now we go on to the yellow. We've excluded patients with obvious non-ischemic mechanisms of their troponin elevation. And now we're going to go to patients with a working diagnosis of an infarct, of MINOCA. And so what you now want to do is you have that patient, you want to sort of think things through, go back, look at your angiogram, make sure you didn't miss any occlusion or anything. Then you want to go back and you want to look at the angiogram, make sure that the echo or the angiogram didn't perhaps suggest Takotsubo. You want to maybe consider an MRI and make sure there's not myocarditis in there. So these are patients with a working diagnosis, but you just sort of, before you say for sure, okay, this is MINOCA, let's go ahead and think about the etiologies, just make sure you didn't miss anything. So here's a patient who's 54 years old. She came to our cath lab from an outside, she was admitted to an outside hospital with chest pain and an elevated troponin. And at the time, she has a history of cardiomyopathy, as you can see a defibrillator here. And she was sent here for evaluation of elevated troponin. And at the time of the cardiomyopathy diagnosis a couple of years ago, she had a cardiac cath that showed non-obstructive disease. So here you can see that she has like lots of lumpy, bumpy stuff, but nothing here that's over 50% stenosed. And here's another picture of the left main, the left circumflex, the ramus, and the LAD, and there's really nothing here that's significantly severely stenosed. Then we go on and we take a look at the right coronary artery, and you're just like, okay, so this is fine. My interventional fellow was doing the case. He basically said, okay, we're done. Take the patient off the table. There's no obstructive disease. I said to him, wait, look closer. And here you can see that there's this total occlusion of the RPL. So it's a blunt, let me see if I can stop it for you. So it's a blunt occlusion right there. So see how this RPL sort of tapers slowly down to tiny, tiny little vessels. This one stops right here. So if you didn't look further at the angiogram, you would miss that, and you would have called it MINOCA when indeed it wasn't MINOCA. It was obstructive disease, whether it was obstructive disease from a coronary embolism because the patient has LV dysfunction and AFib, or whether it was obstructive disease because of plaque rupture at the distal RPL. I don't know, but this kind of case wouldn't be MINOCA, but it would have been in the working diagnosis until you went back and looked at it. So again, I really encourage you to feed back to the interventional cardiologist, have them review the angiogram, make sure you didn't miss things. It is not uncommon that you go back and look and say, oh, you know what, there was something included. This type of thing, we would, by the way, it was too distal, we weren't going to do anything about it anyway. It didn't change the immediate interventional management, but it changes your management in that now they're probably going to get DAPT and hydrostatins, et cetera, as opposed to somebody who you would otherwise have said, well, MINOCA. Okay, so now the green light part of the algorithm is green, go, it's MINOCA. We've done the evaluation, we've excluded everything. Now let's go ahead and look for and consider evaluation to look for the etiologic mechanisms as I've described before. Now it's important to understand that this whole traffic light sequence is very sort of fluid. So you can have somebody who initially you didn't think was MINOCA, you thought it was a myocarditis, and you did an MRI, and then you later find out that there's a late gadolinium enhancement and evidence for myocardial necrosis, and it was in fact an MI. Or you can have somebody who you thought was MINOCA, and when you go ahead and do your evaluation, you find out later that the MRI shows myocarditis. So it's fluid. It's just, this is to the point where we're pretty sure we have MINOCA, and now we're going to do our evaluation. So these are the things that we recommend. Again, this is also very loose because it depends on the hospital and the support and the ancillary services that the hospital has. Not every hospital can do intracoronary imaging. Very few hospitals in the United States do functional testing, and not every hospital has a cardiac MRI. So depending on the situation and depending on the patient's presentation, we encourage that these things be considered and be done on a case-by-case basis. Everything should be individualized. But if you don't have the resources, then depending on the case, you may or may not want to refer out, depending on the situation. So for sure, I always recommend MRIs for all my patients with MINOCA. Why? Well, to me, it helps a lot. If you do an MRI and you see late gadolinium enhancement and myocardial scar, then it really helps support you and be more confident in the fact that this was MINOCA, it wasn't truly an MRI, and we do need to understand it and look into the etiologic causes. The absence of late gadolinium enhancement on an MRI does not mean you didn't have MINOCA. There are some studies that have shown patients with clear-cut MINOCA and plaque rupture on their IVUS or OCT imaging who didn't have abnormalities on their MRI. So if you have such a small infarct, it may not show up on MRI, but the presence, the positive predictive value of a scar on the MRI really supports the diagnosis. Additionally, it helps you because it'll tell you if you do have myocarditis. So this is a study that was done on 204 patients with MINOCA, and they demonstrated that there's a lot of patients who they went in ahead of time saying that they called it MINOCA, non-obstructive disease on CAT. They went in ahead of time saying maybe it was myocarditis, and while 34 of the patients who they thought might have myocarditis had myocarditis, 23 of these patients actually had an MI when they did the MRI. And the flip side of it is these are patients who they thought had an MI, and actually 10 of these patients had myocarditis and not an MI. So you can see that the MRI really helps you to sort of change things. So in this study, they demonstrated that close to a third of the patients, you changed your diagnosis when you were a fourth of the patients, whatever. You changed your diagnosis when you did the MRI. You either went to, oh, it's not an MI at all, or the other way around. So I think an MRI is extremely useful. Now that we have the ability to do it here, I would strongly encourage it in our patients. And in my opinion, because the findings, not so much for infarction, but for myocarditis can change over time, I think it's valuable to do it in the hospital. We definitely don't want to delay hospital discharge, but if you can't do it in the hospital, to do it very soon after discharge. So what about other etiologies for MINOCA? Well, Dr. Reynolds and colleagues from NYU looked at data of about 50 patients, 50 female patients with MINOCA, and they went on to do IVUS on 42 of these patients. And in this study, they demonstrated that in patients with MINOCA, female patients, approximately a third of the patients had evidence for plaque erosion or a plaque rupture on their IVUS imaging. You don't see erosion on IVUS. And so here's one characteristic example of a figure that she showed in the article. You can see that there's really very little plaque here angiographically, but yet when you look at the IVUS imaging, you can see this sort of ruptured plaque. So this is the cross section of the artery, and here's some plaque in here, and here's a discontinuation or a rupture. So they outline it nicely here. So you can see that these were characteristics of the 38% of the patients who had some evidence for ruptured plaque. So it's important to consider IVUS. OCT imaging is probably a better test because it can also help you to see plaque erosion. And OCT imaging has also shown approximately 1/3 of patients have evidence for plaque rupture when you do IVUS, when you do OCT imaging in patients with MINOCA. The findings were also notable that when patients had absolutely pristine coronaries, meaning really, really smooth, there was no evidence for plaque rupture in any of those patients. So that if you have absolutely normal coronaries, the use of IVUS or OCT may be a little less helpful, but if somebody who has 30% plaque, so it's non-obstructed, but there's plaque there, IVUS or OCT imaging should be considered. So here's a patient who had a 42-year-old man. He came in with chest pain and had troponin of 8. You can see again here, this is absolutely clean, pristine right coronary artery. So we went ahead and we took pictures of the right, and then we went ahead and we took pictures of the left, and you can see the left main is nice and clean, and this is the circumflex coming down, again, nice and clean, no evidence for disease. We went ahead into the cranial view. We saw some plaque in the LAD, but really nothing critical, nothing really obstructive, but some plaque. So we went ahead and IVISed it. This was a couple of months ago, and on IVIS, here is the cross-section of the IVIS. So here you can see the cross-section of the artery, and here you can see sort of a big open space. And this is a characteristic appearance of a dissection on IVIS. So this patient had a LAD SCAD, and we were able to sort of understand better the etiology for the MINOCA by doing this IVIS imaging. So what other etiologies for MINOCA can we have? As we talked about earlier, coronary artery spasm can be a definite etiology for MINOCA, and we need to consider it. In the United States, we really don't do that much provocative testing, but there are some centers that do. So whether it's microvascular spasm or whether it's epicardial spasm, you do need to consider it in the right context. When you look at pooled data overall of all of the studies of patients who present with MINOCA in which provocative testing was done, you can see a great variability in the extent to which spasm was detected. Some studies show that no spasm was detected in all of the patients that they evaluated. Some patients showed that 95% of the patients which they did provocative testing had spasm. Now again, the 95% is probably a selection bias in that these studies were done in Japan or some of the Asian countries in which there's a higher rate of coronary spasm, and maybe they were more provocative in their testing. But you can see that overall the rate of spasm occurs in about 1/4 of patients with MINOCA if you do provocative spasm testing. So this is a case we had done a couple of years ago now. Here is somebody who comes in with chest pain and abnormality on their troponin, an elevated troponin. We take her to the cath lab, and she has a very severe kind of diffuse disease of obtuse marginal 1. And over here, you can see a very severe stenosis of the obtuse marginal 2, and it's a big vessel that goes all the way out to there. So in keeping with how we do things, we gave nitroglycerin because that's what we do before we do any kind of PCI. And after nitroglycerin, you can see that it's really nice and robust. There's no more disease. Now, obviously, this patient would not have been classified as MINOCA in the first place because she had obstructive disease on the initial angiogram. But I sort of show this as a provocative, thoughtful slide, because what if we had done the angiogram and this is what we saw, which is what her arteries look like. So what if we had started and she wasn't in active spasm at the time? We would have seen this, and we wouldn't have considered coronary microvascular spasm. So you do need to consider it in patients, and it's not always obvious. But if you can't do provocative testing, which we don't do, and if they're not having active spasm at the time of their cath like this lady had, then the question is it the right clinical context? Did they use cocaine, or do they have repeated episodes of coming to the hospital with some mild troponin elevation? Then you might want to consider giving them treatment for spasm. Other etiologies for MINOCA, as I mentioned earlier, include thrombophilia. So this is patients with coronary thrombosis. Now again, you can have either embolism as a result of thrombosis or spontaneous arterial thrombosis, which is rare. When you look at the studies of patients with MINOCA and you look at the studies in which thrombophilia testing was done, you can see that overall about 14% of patients with MINOCA who have thrombophilia testing have some abnormality. I think I would give this a lot of caution because there's a lot of incidentally noted abnormalities in hematologic studies in patients in general. So it's possible that this is just sort of an association, but not necessarily the cause. But we do know that that is a potential etiology. And so if you have somebody in the right context and they've had a family history of thrombosis, they themselves have had arterial or venous thrombosis, or if they've had frequent miscarriages, you may want to consider doing thrombophilia testing. But if it comes back abnormal, I would definitely work with a hematologist before saying, oh, they had MINOCA and this is the cause. We should treat empirically with anticoagulants unless the hematologist felt that it was the right appropriate thing for the patient in the overall subset. So in keeping with the etiologies, and again, the importance of understanding the need to do etiologic-based testing, when we have MINOCA, if we understand the etiology, then we can understand the best way to treat these types of situations. So the treatment will differ depending on the etiology. In the most obvious case, if it's plaque rupture, you're going to give certainly one antiplatelet and probably 2 antiplatelets, because this is really no different than an MI patient with non-obstructive disease in which dual antiplatelet therapy has been shown to be beneficial. you're going to definitely give statins because they have some degree of plaque and probably a beta blocker. On the other hand, if it's coronary artery spasm, you might be giving a calcium channel blocker, and you might consider a statin. If it's microvascular dysfunction, which is a little harder to sort of tease out, but if it's microvascular dysfunction, there's a lot of strange therapies, L-arginine and ranolazine and aminophylline and alpha blockers, etc., that can be used for microvascular dysfunction beyond the usual calcium channel blockers. Sorry, I thought somebody said something. And then, of course, if it's coronary embolism or thrombosis, you would want to consider antiplatelet or anticoagulant therapy. Again, I personally would get the help of a hematologist unless you guys are really comfortable with just administering the anticoagulant on your own for abnormal testing. SCAD patients should be treated with aspirin, potentially clopidogrel. There's some data, it changes every single month. Depends on the way Dr. Saul wants the expert in SCAD. But the last I heard, she was using it for at least a month after a presentation with SCAD. You might want to consider statins in patients with SCAD as well. And then, of course, for supply-demand imbalance, you're going to try to understand the underlying cause. So these are all etiologic-based mechanisms. But the big question is there a role to just like we treat patients with beta blockers after an MI or ACE inhibitors or statins, is there a role to just give cardioprotective medications to patients with MINOCA, even if they don't, even if we don't know the etiology, or even if we do know the etiology, is there still a role because they technically had an infarction should they be given beta blockers? And unfortunately, in the world of MINOCA, we don't really have any randomized trials. So the answer to that question is I don't have an answer for you, but the bottom line is that we do have some observational data to suggest that there may be a role for cardioprotective medications. So in this observational study of 9,000 patients with MINOCA from Sweden, the investigators, because they have a very good EMR, sort of registry type EMR, they're able to follow these patients long term. They were able to see them up to 4 years of follow-up. And in patients who were treated with statins and ACE or ARBs, there was a significantly lower event rate, MACE rate, in patients who had MINOCA who were on statins or ACE or ARBs compared to those patients who had MINOCA and were not. Again, this is observational, but it did show a lower event rate. We also saw a borderline lower MACE rate for beta blockers with a significantly lower all-cause mortality when patients were on beta blockers compared to MINOCA patients who weren't on beta blockers. But you really didn't see any benefit to patients on DAPT. So it's not clear whether DAPT itself is needed in all our MINOCA patients. And again, these are MINOCA patients across the board. They're not etiologic based, so maybe there'd be a difference in outcome depending on the type of etiology. But there's some suggestion that maybe statins, ACE or ARBs, and certainly beta blockers might be cardioprotective to patients with MINOCA. Now, this was further supported by data from the Khmer registry, which is the Korean acute MI registry. And in this study, they looked again about in this case, there was actually about 10,000 patients. Okay.
Good New York City client.
Oh, thank you. Thank you. I thought he was going to take me off the stage with a big yank. So I had to leave. Okay, so this is data from the Khmer registry, and in this registry also they showed that the independent predictor of adverse events in patients with MINOCA was if they were not on a beta blocker, or ACE or an ARB, or if they were not on a statin. So again, in this registry too, we see some data to suggest that ACE or ARBs and statins are cardioprotective to patients with MINOCA. Again, this is observational data, but it's really the only data we have. So looking forward, there is a MINOCA BAT study, which is currently enrolling in Europe, and I believe they're trying to get enrollment in the United States. They might have started enrolling here too. They're aiming to enroll approximately 5,500 patients with MINOCA and to randomize them to a strategy of beta blockers or no beta blockers, and ACE inhibitors or no ACE inhibitors, or ACE or ARBs or no ACE or ARBs, and to see whether there's a routine benefit to routine use of ACE inhibitors, ARBs, or beta blockers in patients with MINOCA. And right now we don't know the answer to that question, but that is currently underway. So what about the prognosis of patients with MINOCA? Well, the pooled data, and a lot of the data would show that patients with MINOCA, as compared to patients with MI and coronary artery disease, generally fare better. So you can see here, the pooled data of comparative studies, there's a significantly lower event rate in hospital and at 1 year in patients with MINOCA compared to patients with MI and CAD. But the overall event rate is not low. It's about a 1% mortality rate in patients with MINOCA before hospital discharge, and about a 5% mortality rate in patients with MINOCA at 12 months. So this isn't a trivial diagnosis, and it does carry a guarded prognosis. When you look at the long-term data over time, you can see that over 10 years, approximately 14% of patients with MINOCA will die, and 24% will suffer a major adverse cardiovascular event. This is taken from data from the Sweetheart Registry, again, observational. Again, we don't know the underlying etiology for their MINOCA, but you can see that this isn't a trivial condition. And finally, when we look at data from the Khmer registry, the Korean acute MI registry, they took patients and they adjusted them. So in general, most of the data I just showed you was raw data comparing patients with MI, CAD, and MINOCA. But in this study, they went ahead and risk adjusted. So patients with MINOCA are generally younger and generally healthier than patients with MI and coronary disease, and they generally have fewer risk factors. So when you look at patients with MINOCA and you adjust for the fact, or you do propensity adjustment, or adjust for the fact that they have fewer risk factors, the actual outcome in terms of death or MI is similar for patients with MINOCA compared to patients with MI and coronary artery disease over a 2-year time period. Now, of course, any repeat revascularization is going to be lower in MINOCA because they didn't have obstructive disease, so it's a lower chance you're going to need another revascularization because you didn't have a revascularization in the first place. Any revascularization will be lower. So I think there's still a lot of unanswered questions. I hope I sort of informed you on the diagnosis of MINOCA and the importance of trying to understand how we evaluate these patients. But now that we've finally sort of just, understood the approach, the formal definition, the potential etiologies, and the approach to MINOCA, now we're going to sort of have to revisit all of those studies that looked at the prognosis and looked at treatment and so forth, and look at it by etiologic-based outcomes. So what is the true incidence of MINOCA if we use the formal definition? So all of those studies I showed you were essentially patients in randomized clinical trials who were sent to the cath lab and had non-obstructive disease. But some of these patients may not have had an infarction at all because they could have just had a myocardial injury the way we define it now, whereas years ago we didn't really use that term. So what's the true incidence of MINOCA in patients with true MI, ischemic-based mechanism for myocardial injury, as opposed to Takotsubo or as opposed to myocarditis? So if we exclude those patients, are we still left with a 6% incidence, or is it more like 3 or 4%? Excuse me. What is the relative prevalence of the etiology? So as I sort of showed you, 35% of patients with MINOCA can have plaque rupture, and about a third of them can have, about a fourth of them can have coronary vasospasm or some sort of hypercoagulable state. But what is the true incidence of each of these etiologies? So I think the only way you would know that is if you equally tested or assessed with similar protocols every patient with MINOCA. So if they went into the cath lab, every patient with MINOCA should have IVUS or OCT imaging, MRI, and should have potentially provocative testing done and thrombophilia testing. And we don't do that right now, but I think future studies should focus on that and really get a better understanding of the relative proportions, so we can give you a pie chart of what, when MINOCA patients present, what percent do they have vasospasm, what percent have coronary microvascular dysfunction, what percent have fibrosis, etc. The question is, what is the prognosis for MINOCA? There is some data looking at etiologies for MINOCA and outcome, but the data is very few numbers, so I didn't even show it to you. Nobody really knows whether MINOCA, depending on the underlying etiology, has a different prognosis. There is some suggestion that MINOCA from patients with coronary artery disease, but not obstructive coronary disease, do worse than patients with MINOCA who have pristine arteries. That would be intuitive, and there's some observational data to suggest that. But the question is really, what is the prognosis based on etiology? Are certain MINOCA patients going to do worse than others? And then finally, as I pointed out, we don't know which medical therapies improve outcome just as a routine use. Should we be giving aspirin to every one of our patients? Should we be giving the statins and the beta blockers and the ACE or the ARBs to all our patients just as a routine cardioprotective way? I would encourage that obviously if anybody's had a large infarct, I would generally give a beta blocker, so if the troponins 9 or something, I don't think it's any different than any type of MI, and you want to treat with beta blockers, but this is really not evidence-based. And I would certainly say if there's any indication for ACE, like early dysfunction or hypertension, diabetes, you might want to treat with an ACE or an ARB. I generally give aspirin to most of my patients unless there's a concern about aspirin, but the second antiplatelet products or certain other agents for platelets would be reserved for patients who I felt had true plaque rupture. So in summary, MINOCA is not uncommon and it occurs in about 4 to 6% of patients. A larger proportion of women with AMI present with MINOCA compared to women with AMI who have obstructive CAD. You should always remember the traffic light algorithm for assessment and treatment of patients with MINOCA. The treatment will vary depending on the underlying etiology, and that's why it's important to understand what the etiology for MINOCA will be. But there is some data to suggest that cardioprotective medications overall may be helpful for patients with MINOCA. And finally, the prognosis of MINOCA is not benign, and it's important that we inform our patient and we try to work with them to get them the best therapy so they have the best prognosis. In conclusions, don't tell your patient that they had an infarct when they didn't, and don't tell your patient that they didn't have an infarct when they did. Thank you.
Jackie, that was really some presentation.
Thank you.
New York City hosts the New York Marathon, and every year we see patients in the ED who come in with sky-high CPKs after running the marathon, with chest pain and elevated troponins. I'm talking about MINOCA before you do your coronary angiography, because obviously you can't find that without coronary angiography. But what about the step before that, when you're faced with possible supply demand ischemia?
Right. So just like you said, it's not uncommon to see elevated troponins anyway. So I think for me personally, I would distinguish it by making sure that they had a true ischemic symptom. So if they had the chest pain and the troponin was appropriate rise and fall, then I would suggest that it's an MI, and I would call that a type 2 MI. What I would do for these things, I think that, if we're not quite sure and the patient had chest pain and significant elevation of the troponin, I would definitely give the DAPT until we did the angiogram, and I might give heparin depending on the situation. Although we would all agree that this is probably a type 2 MI, we don't know for sure until we take them to the cath lab. So I would, my bridge to the cath lab would be that, and then I would like to do a cardiac cath, or if you really wanted to do a CT angiogram.
Well, a follow-up question would be your first step be the cath, or would you consider other studies before doing it?
Is Harvey Hettener? So my first step would be the cath. And again, MINOCA, we're very careful to say that MINOCA patients, we can expand the diagnosis or extrapolate to patients with coronary CT angiograms, but there are limitations to CT angiograms. So the MINOCA really only is MINOCA if it's diagnostic angiogram that show non-obstructive disease, although we can extrapolate that diagnosis to patients who've had coronary CTAs. But I've had a couple of patients who've had the troponin of 5 and the coronary CTA that shows non-obstructive disease, and I still recommended the angiogram just to be sure they weren't missing something, just to be sure.
Couple of things. It just seems to me, from the presentation, that the MINOCA is part of a gradation of disease, of severity, and whether you have dead cells versus damaged cells. So if that's the case, are we just seeing a spectrum of a progression of a process, no matter how you slice it, as an abnormality that caused either an injury or death? That's the first way to think of it. And maybe by reclassifying these things maybe help us to understand better how it happened rather than what's the best thing to do. The other is, since it appears to be more common in women, it appears also to be younger age. How much does menopause and its initiation contribute to alterations in vascular flexibility, et cetera, to, is anybody looking at that from the standpoint of origin of disorder when the menopause occurred?
Yeah.
And then there was no data at all on how many of these people, being women, and the differences in different countries, is that obesity, diabetes, and hypertension, which can maybe factors that go to the etiologies.
Yeah, no, absolutely. I think that it's definitely a spectrum, and I think that, you know, the argument could be had that when we introduce our high sensitivity troponins, will we be uncovering more patients with MINOCA, or again, the other way around, will we be overdiagnosing patients with myocardial injury? And there is a spectrum, but Harmony Reynolds would argue that there's probably a lot of patients with MINOCA who just are not mounting a troponin, have true MINOCA, but with the high sensitivity troponins, it'll uncover more. So it's definitely a spectrum. In terms of the question about the evaluation of women before and after menopause, I don't believe there's anything ongoing looking at that, but that is an interesting thought. There's a lot of question about why younger women do develop coronary disease at a younger age, or do have infarctions at a younger age, and whether there's some role of estrogen or lack of estrogen that relates to it.
Jackie, thank you for a great presentation. I can't help but mention, you know, my dad would have 92 today, and his favorite dessert was tapioca. So, you know, sitting here, I think, it's such a nice, you know, just reverberation for me. I'm just curious, you know, Jackie, reflecting on your work on various writing committees for the AHA and ACC, and how we're managing acute coronary syndromes. For, you know, much of the country where the MR and ultrasound technology can't be brought to bear, are there proxy studies that people should be thinking about doing, and just how you're thinking about making recommendations on MINOCA for those providers?
Right, and I think that was an important thought to us, because it's not even just the rest of the country, but the rest of the world. There are certainly areas in the world where cardiac MRI is not available, and neither is IVUS or OCT imaging. So I think that, you know, the bottom line is, if you think about the different etiologies, and even if you don't have the mechanism to be able to do those particular studies, you can at least head in the right direction. So if you see plaque that's 30%, while you don't know for sure, you would say statistically there might be a third of these patients with 30% plaque who have rupture, and certainly you want to give statins and at least one aspirin, but maybe a second depending on the situation. So I think you have to just sort of go with your, you know, what your best clinical judgment is. And again, that just boils down to the importance of clinical judgment from the very start, going back and looking at that case and saying, is this a true infarction at all? But interestingly, we met with when they were creating the universal definition of MI, we were supposed to publish at the same time, but we were behind. So they were going to put this document out at the same time with the universal definition of MI, but we had met with them because in order for us to define MINOCA, we had to define an infarct, and we needed to be sure that we had the same definition they had. So they provided us with their definition of MI in order to put it in the document, and then we provided them with a paragraph on MINOCA for their document. So we sort of worked together on it, so that way we can be consistent and there was not any conflict between what we both said.
Jackie, what percentage of your MINOCA patients have transmural?
Can I ask a question from uptown?
Sure.
I'm concerned about my reading that biotin in vitamin pills always tends to interfere with the troponin test. How much does this interfere, and how is this considered when you do these studies? As I find that almost every person over 55, which is practically every patient I see, takes some kind of supplement.
Yeah, no, actually, that's a great question, but unfortunately, that's, I think, the problem with any of the observation studies is we really don't have a detailed history. So if you wanted to add biotin to your database of questions you can ask your patient, if we did a prospective registry of MINOCA patients, that can certainly be one of the things you ask. But again, going back to the original diagnosis, even if the biotin basis is troponin, unless you've had a clinical syndrome to suggest an infarction, it's probably not MINOCA anyway, because you have to have a clinical syndrome, not just the elevated troponin.
Jackie, what percentage of your MINOCA patients have transmural infarctions as manifested by Q waves, and how does that affect their prognosis?
Yeah, so I don't have the information on QAs, but like, as I had shown in the slide, about 15 to 30%, depending on the study that was looked at, have steady as they're presenting findings. So I don't know if that would manifest into QAs, but that's what we would consider transmural infarct.
How about the prognosis?
I don't know the prognosis. They don't really talk about prognosis in terms of presenting.
Dr. Tamis-Holland, thank you so much.
Yeah, thank you so much for giving me the opportunity.